Hi friends, welcome to Plexus Ortho. My name is Dr. Kanan Kumar. I am your upper extremity consultant at Plexus Ortho. Today we are going to begin a three-part series on brachial plexus injuries. This is for orthopedic postgraduate residents. This contains a lot of points both for the theory and practical exams. So let's begin with the first part today regarding brachial plexus injuries. So we are going to deal a little bit about neural anatomy. We're going to also discuss about nerve injury classification and its basic signs, plexus anatomy, which is very important, a little bit about the history of brachial plexus injuries and their management. A lot has changed over the last 2-3 decades where the management of these injuries has improved considerably and we can do a lot of good things for patients now. Options for restoring nerve function, their indications and principles. So we're going to go through these topics in three different videos. So let's begin with the first part of this presentation, that is anatomy. So going to the anatomy, spinal nerves start from the spinal cord, from the ventral rootlets and the dorsal rootlets. The ventral and the dorsal rootlets combine to form the spinal nerve. The spinal nerve then divides into a small twig called as the dorsal ramus, which goes to the posterior part of the chest and gives sensation there. The ventral ramus is the main nerve which continues as a peripheral nerve or the brachial plexus, continues to form the brachial plexus. What are the components of the brachial plexus? The components of the brachial plexus are basically C5, C6, C7, C8, and T1. Sometimes there is a contribution of the plexus from the C4. What is it called? It is called a prefixed brachial plexus. Sometimes there is a contribution from T2. This is called as a post-fixed brachial plexus. So prefixed and post-fixed. This question may be asked in your exams and practical, so you must remember this. C4 is a prefixed brachial plexus and T2 is a post-fixed brachial plexus. So any nerve that does not arise from C5 to T1 is called as extraplexal nerves. And nerves which arise from C5 and T1, combination of the plexus of these nerves are called as an intraplexal nerve. So why are these extraplexal nerves important? Extraplexal nerves provide donor nerves to when these intraplexal nerves are injured. So remember these terms, extraplexal nerves and intraplexal nerves. So how do these arise from the neck, or how do they arise from the spinal cord? What is anatomy? So here you can see the sternocleidomastoid muscle that has been removed or cut from the in this picture for illustration purposes from the clavicle. Behind it is the scalenus anterior muscle. So we know there are three scalenus muscles: scalenus anterior, scalenus medius, and scalenus posterior. Between the scalenus anterior and the scalenus medius is the brachial plexus and the subclavian artery. And between the scalenus medius and the scalenus posterior is the subclavian vein. So this portion, if the subclavius, the scalenus muscles become fibrotic and they become thick, they can compress the brachial plexus nerves and cause thoracic outlet syndrome. So this is an important concept. Should understand where the nerves can get compressed. So there's one important pictorial depiction here of the phrenic nerve, which lies on top of the scalenus anterior muscle, that is in between the sternocleidomastoid and the scalenus anterior. So this nerve is important because it's extraplexal. This is extraplexal nerve. This arises from outside the plexus, and this can contribute, or we can use this as a donor muscle to re-innervate the suprascapular nerve or any other nerve which is close by damaged. And this phrenic nerve contains a good number of motor axons, and therefore it's a good donor nerve for intraplexal or brachial plexus injuries. So this is another illustration of how these nerves arise. So basically brachial plexus is the spinal nerves arising, intermingling with one another, and then becoming peripheral or end nerves or terminal branches of these brachial plexus. So basically you have the roots, you have the plexus, and then you have the peripheral nerves. So they come in between the scalenus anterior and the scalenus medius. They go under the clavicle, they become infraclavicular. They are all around the axillary artery at the level of the infraclavicular portion, and then they become terminal branches. So basically, you start off with roots. The roots are, as I've said, C5, C6, C7, C8, and T1. then you have the trunks, then behind the clavicle, they become divisions. This is behind the clavicle. So what is the clinical correlation? Sometimes if the injury is at this level, you need to do a clavicular osteotomy to access these nerves at this point. Then the divisions become cords, and then the cords finally give rise to the various branches that we see in brachial plexus. So what are the roots? C5 and C6 roots. C5 and C6 roots combine to form the superior or the upper trunk. The C7 root continues as the middle trunk. The C8 and T1 roots continue as the inferior trunk. So what are the branches from the roots? Before we proceed, let's see the branches. This is a long thoracic nerve, or the nerve of Bell, which goes to the serratus anterior muscle. It arises from C5, C6 and C7 nerve roots. What is the significance, clinical significance? If this nerve is intact, that means it indicates that the injury is distal to this point. That means it is a postganglionic injury. And if the nerve is injured, that means the nerve injury is proximal to it, and it is called a preganglionic injury. Why should we differentiate between preganglionic and postganglionic injuries? Preganglionic injuries cannot be grafted. That means they are avulsed from the spinal cord. Whereas postganglionic injuries, we still have the nerve root intact to the spinal cord, and therefore you can graft the area. So what is the importance of these branches? That is a nerve to the serratus anterior or long thoracic nerve. The nerve is important because it indicates pre or postganglionic injuries. What are other branches? This branch is a nerve to the rhomboids, and this is a dorsal scapular nerve and the nerve to the rhomboids. So these branches supply the and help in the protraction of the scapula, and therefore they are also a good clinical indicator to diagnose preganglionic injuries. If they are intact, then it is a postganglionic injury. If the protraction of the scapula is absent and rhomboids are not working, then it indicates it is a preganglionic injury. So these are the two branches from the roots. The upper, middle and lower trunk have only two branches, and both the branches arise from the upper trunk. The two branches are the suprascapular nerve, is a very important branch from the upper trunk. The second branch is a nerve to the subclavius. This is an unimportant branch, and this we will not discuss further regarding this nerve. So there are two branches which you have to remember. One is the suprascapular nerve. The second branch is a nerve to the subclavius. The suprascapular nerve supplies two muscles. What are the two muscles? They are supraspinatus and infraspinatus. These two muscles. What is the function of the supraspinatus? Abduction of the shoulder from 0 to 30 degrees. What is the function of infraspinatus? It is external rotation. So these are the two muscles that is supplied by the suprascapular nerve, and this is called as the Erb's point. What is it called? It is called as the Erb's point. Why is this point very important? Because many of these brachial plexus injuries occur at this level, at the trunk level, and therefore you will have the suprascapular nerve injury, and it's very common. So this has been termed as the Erb's point. It can be commonly asked in your practicals. You should be ready to answer this question. So let us now go on to the divisions. So behind the clavicle, they divide, all the nerves divide into anterior and posterior divisions. The divisions are important because they don't give away any branches. So if some examiner asks you what are the branches from the divisions, you should say there are no branches from the divisions. So the anterior division of the upper and the middle trunk, continue as a lateral cord. The posterior division of all the trunks continue as the posterior cord, and the anterior division of the inferior trunk alone continues as the medial cord. So the divisions, each trunk gives rise to anterior and posterior divisions. Anterior division of the upper trunk and the middle trunk continue to form the lateral cord, whereas the posterior divisions of all the trunk form the posterior cord, and the anterior division of the inferior trunk continues as the medial cord. The lateral cord then gives out the end branch, which is the musculocutaneous nerve. It also gives a contribution to the formation of the median nerve. The medial cord also gives a contribution to the formation of the median nerve, right? So these cords, lateral cord, posterior cord, and medial cord, are described anatomically in relationship to the axillary artery. So the lateral cord is lateral to the axillary artery, posterior cord is posterior to the axillary artery, and the medial cord is medial to the axillary artery. So the posterior cord gives away the following branches: thoracodorsal nerve, the middle, upper subscapular nerve, lower subscapular nerve, and the terminal branches are the axillary nerve and the radial nerve, right? Medially, we have two cutaneous branches from the cord, which is a medial cutaneous branch of the arm and medial cutaneous branch of the forearm. And it also gives a contribution to the median nerve, as I've described. And the terminal branch is the ulnar nerve. And the terminal branch is the ulnar nerve. Two pectoral branches also arise, one from the lateral and one from the medial. They supply that is a lateral and medial pectoral branches, and they supply the pectoralis major, which is a major adductor and a secondary flexor and internal rotator of the arm. So that is the basic anatomy of the brachial plexus. So you have seen a lot of pictorial and illustrations of these brachial plexus, but when you actually go and dissect this out, it's a big mess as shown in this picture. So one must remember that brachial plexus, which are depicted in pictures and which are actually seen inside the body, are very different. And you should be well versed with the anatomy to be able to recognize these structures. So this is just an illustration to tell you that you have to do a lot of dissection to delineate the anatomy of the plexus. Now let's go to a little bit about the microscopic or histologic anatomy of the neurons and axon. All of you know that the neuron or the cell body is quite proximal. It's either at the spinal cord or it is at the dorsal ganglion for sensory purposes. But the motor neurons are at the level of the spinal cord. It gives out a long axon which reaches the end organ, that is the muscle. So the axon is a continuation from the neuron. On the neuron or the cell body lies in the spinal cord. This is very important because any injury, the axon cannot suddenly grow from where the injury has happened. So the axon is coming from the cell body. So this is an important concept to understand for Wallerian degeneration. Why it takes such a long time for a nerve to recover? Why is there such a poor growth potential of these nerves? So this is a very important concept that we must understand. So further microscopic anatomy of the nerve as a whole. So nerve has three coverings. The outer covering is called the epineurium. Inside, the vesicles are covered by the perineurium. The vesicles have axons which are covered by the endoneurium. So to go backwards again now, we have the axon or the outpouching from the dendritic outpouching which extends up to the end organ, that is called as an axon from the cell body. It is covered all around by a myelin sheath. How is this myelin sheath formed? Myelin sheath is formed by a Schwann cell. Why this myelin sheath is important? This myelin sheath increases the speed of conduction. So therefore, the speed at which the nerve conducts the electric potentials from the cell body are hastened by the myelin sheath. And how are these produced? They are produced by Schwann cells. This is covered by what is known as an endoneurium. The axon is covered by what is known as an endoneurium. Multiple of these axons get together and form a vesicle, which is covered by what is known as a perineurium. And a multiple of these vesicles are further covered by an outer covering, which is called as an epineurium. How do you remember epi and endo? P comes after N. So therefore, P is outer, that is epineurium is outer, endo inside. So endoneurium is an inside covering of the axon, and perineurium is in between these two. Why is this important? It is important because you have to differentiate between the various types of injury, that is a Seddon's classification and Sunderland classification, which we are going to discuss in more detail.